Yeah, so the main point of this slide is that HPV is the most common sexually transmitted infection. Studies have reported that 80 to 90% of people will contract HPV at some point in their lifetime. The vast majority of cases will clear on their own, but of course, due to, and what's your background?
I'm a lawyer, but
you're a lawyer, okay.
I have a pretty good HPV background. I work with HPV biotech.
Okay, just wanted to make sure you didn't have a medical background, and I was boring me to death. Okay. So the vast majority of people can clear an HPV infection.
How long is that usually?
So we don't really know because they can be so transient that that it's hard to study, because when we see a patient and we have a positive HPV test, it's hard to tell
right.
how long the HPV has been there.
Right.
But we do know that, so there's low risk and high risk, and the high risk types take longer to clear. It could be sometimes as little as a few months. Sometimes it could take a couple of years.
Okay.
Yeah. And another major point is that women a lot of times will be confused about if we find an abnormal test result. Sometimes women will be confused as to whether or not they have cancer or not, because the doctor will, rightly so, explain to them that this could be associated with cancer, but for the vast majority of cases, it's a precancerous lesion that we're detecting. But we want to emphasize the importance of treatment, which is why we should, counsel patients that they need to get treated, if not, it could lead to cancer. So cervical cancer in the United States really is not very common. About 12,000 women are diagnosed with cervical cancer per year, and cervical precancers are diagnosed a lot more often than invasive cancer. So how old are people when they get cervical cancer? So most cases develop in middle-aged women. So you can see, the vast majority of cases develop in middle-aged women, usually less than 50 years old, but it is important to note that older women can still develop cancer. And it's very rare for cervical cancer to develop in women younger than 21, so it's really less than 1%. The reason why this is important is because this has to do directly with screening guidelines. So this shows us why the current screening recommendations are for women to start their PAPs at age 21 and younger, not to get PAPs at 21, less than 21, and then also if a woman has had normal Pap smears for the duration for a good 10 or 20 years, then they can actually stop at 65. These women who are getting cervical cancer above the age of 65, it's usually because they haven't gotten their screening throughout their lifetimes, and now we're finding them later on. HPV infection, sexual history, smoking, other sexually transmitted infections weaken immune systems, and not getting regular checkups. And I'll go over these in detail. So HPV, it's the most important risk factor for cervical cancer. It is the cause of cervical cancer. Risk of getting HPV infection can be reduced by using barrier contraception, such as condoms. Again, there's no treatment or cure for an HPV infection. And just for everyone's peace of mind, only a small percentage of women with an HPV infection will develop cervical cancer, because most people will clear the infection. So because HPV is a sexually transmitted infection, it's a primary cause, a person's sexual history is a risk factor. So, for example, the higher the number of sexual partners, the higher the number of the sexual partners of your sexual partners. Also, the younger the age a woman starts to have sex, and those, basically the more partners you have, the more sex you're having, the more at increased risk you are at getting HPV. So smoking is a risk factor because chemicals associated with smoking can be found in the mucus of the cervix, and just change the environment of the cervix in order to make it more difficult for the body's immune system to clear the infection. So having a weakened immune system is also a risk factor, but we're talking about seriously weaken immune systems like HIV, or patients that have had a organ transplant who are taking medications on purpose to decrease their immune system. And the reason why I emphasize that it's serious is because, it's not like you can take antioxidants and increase your risk of, improve your immune system. Of course, eating fruits and vegetables is always a good thing, but we wish it was as easy as that. So other sexually transmitted infections can also increase your risk. Cervical precancer and cancer can be detected with the Pap smear and HPV test. And we see it time and time again, women that don't get the regular screening are at increased risk for cervical cancer. So prevention, again, regular screening, and I talked about this a little bit already. The recommendations are 21 to 65. HPV vaccine is another great way of preventing cervical cancer and avoiding risk factors if you can. I wanted to talk a little bit more about HPV vaccine. Currently there's 3 HPV vaccines that are licensed in the US. They cover different types of HPV. So again, there's high-risk HPV and low-risk HPV. High-risk HPVs are associated with cervical cancer. Low-risk is associated with genital warts. I'm only talking about the high-risk HPV vaccine in this talk. 16 and 18, HPV 16 and 18 cause about 75% of cases of cervical cancer. And as you can see, they're covered by all 3 different types of vaccines. 6 and 11 are the 2 most common low-risk HPV types. So these are the 2 most common HPV types that cause genital warts. And so you can see that they're covered in these 2 vaccines. And then these ones are other high-risk HPV vaccines that are other high-risk HPV types that are also commonly associated with cervical cancer. So this one just came out. So for the most part, when you're going to the doctor, we're using pretty much this one now. And because it has the broadest coverage. Although historically, people that have gotten these 2 vaccines are still covered very, very well. So it's given at 0. It's the first dose is given, the second dose is given 2 months later, and then the third dose is given 6 months after the first dose. So we all talked a little bit about who should get cervical cancer screening, but I also want to talk about who should get the vaccine. So the current recommendations are for both girls and boys to get vaccinated at 11 or 12 years. But it can be started as early as 9. And for those who are not previously vaccinated, that we do recommend that you can still vaccine up to the age 21 26 for females and 21 for males. I won't go too much into detail as to the difference in age as to what the cutoff is. Well, it's basically, I'll just leave it at that. But it's important to note that it's recommended for adolescents because ideally it's before any sexual exposure happens. It's still, the studies have shown that it's still effective in women, women and men in their mid-20s. But it's the strongest response is going to be seen in the adolescent group. And there's also tons of studies showing that, the HPV vaccine is, vaccines in general are a little bit controversial right now, but particularly the HPV vaccine, because, a lot of concerned parents think that it's going to encourage sexual behavior. Tons of studies have shown that it doesn't. So what are the symptoms? So this is really important to know that women with early stages of cervical cancer often don't have any signs or symptoms, which is important. This speaks to the importance of getting regular checkups. Symptoms usually don't start until the cancer becomes much more advanced. And so these symptoms can include pelvic pain, pain during sexual intercourse, and just any sort of abnormal bleeding, and this could be bleeding or spotting after sex, bleeding or spotting in between periods, bleeding or spotting after menopause, or even if your periods are a little bit heavier or last longer than usual. Sometimes we also do see a vaginal discharge that can be watery, bloody, or have a foul odor. So how do we, let's see, it's 15. So the two main types of cervical cancer diagnosis, so there's screening. First we screen for cervical cancer, and then we diagnose it. So there are two screening tests, there are Pap smear and HPV, and they're both performed during the pelvic exam. So I wanted to go over what the pelvic exam is, because a lot of women don't know what a pelvic exam is, even though they get them. Or they confuse a pelvic exam for a Pap smear. Basically what happens is that a woman will go to see their gynecologist. They may or may not get a Pap smear, but they'll get a pelvic exam, but they'll say that they've gotten a Pap smear. Okay? So basically a pelvic exam, you're just doing an internal exam of the female reproductive tract. So a patient's on the bed, and we have them up in stirrups, and then we insert a speculum, and this is a speculum. A lot of women don't know what this is called, but it's the tool that we use we insert it into the vagina, and then the uterus and the cervix are at the top of the vagina, and so what we're doing is looking at the cervix. The speculum opens the walls of the vagina, and so we can just inspect that entire area. So here, this is a woman spread eagle, and the speculum is inserted into the vagina, and so this is the cervix, which is what we're looking at, and then we're also looking at the walls of the vagina. And the next step is to actually do the Pap smear, and the Pap smear, all it is just taking a, so we have the speculum inside, and then all it is just inserting a plastic spatula and just rubbing the surface of the cervix. So this is what we see at the top of the speculum, and then all we do is just a quick swipe, and then we insert this other little brush inside the cervical canal. So then after we collect the cells in this fluid, then we examine the cells on a slide underneath the microscope to look for any abnormalities. And we can actually use the same sample to test for HPV as well. So it's really just collecting a sample of tissue from the cervix. So cervical cancer screening, we talked about this a little bit already. We start at 21, stop at 65, and this has changed a lot recently, actually. So right now we're recommending a Pap test really every 3 years. The old adage of getting a Pap smear every year, that's no longer indicated, and that's because we now know a lot more about how long abnormalities take to develop. We also do concurrently an HPV test along with the Pap smear. So the Pap smear is just to look at the actual individual cells. The HPV will tell us if there's the HPV test will tell us if there's an HPV infection. And if both of those are normal, then the screening can be increased to every 5 years. It's a little bit confusing. It used to be a lot easier for women just to come in and get a test every year, but now it's just basically just come back when your doctor tells you to come back, because they're telling you very specifically based on your age and based on the results of both of your tests. So I say that, first there's diagnosis and then there's screening. So the screening test will just say, oh, well, there's some abnormal cells there, or you have an HPV test. But we actually need a biopsy for a diagnosis. And a biopsy is basically just taking a sample of the tissue. And this looks really scary, but the cervix actually doesn't have any nerves on it. The vagina does, but the cervix does not. And so we'll just take a little bite of the cervix in the same format of doing a pelvic exam. And then that is going to give us the actual diagnosis. And this is another reason why women get confused about actually having cancer, is because and this is what the biopsy will show us. A lot of times we'll say to a woman, well, you have a grade 1 lesion, which is likely to go away on its own, and you don't need any treatment. Or you have a grade 3 lesion, which is 30 to 50% risk of progressing to invasive cancer, so you definitely need treatment. But anyways, back to my point is that they hear grade 1, 2, and 3, and sometimes can think stage, which is related to cancer. So it's called a LEEP procedure, or a loop electrosurgical excision procedure, and we basically just take a wire loop that's heated by electricity and just literally just swipe and remove this area. And the other way of doing it is called a cold knife cone biopsy. So this we actually go to the operating room for, and instead of using that wire loop, we actually, and again, the patient is in the operating room similar to in the office. The patient is placed in stirrups. We put a speculum in to visualize the cervix, and instead of using a wire loop, we actually use a scalpel to cut around the abnormal area that we would like to remove. And the reason, so the vast majority of cases are treated with the LEEP. Reasons to do a cold knife cone would be if you're worried about an invasive cancer, because since we're using that wire loop, it kind of burns the bed of the cervix, and so it makes it difficult to look at the tissue underneath the microscope. But with the cold knife cone, it's a cleaner cut of the tissue, so we're able to look at it a little bit more definitively. But this isn't really done very often at all. Another reason to do it is, for example, if so this is the cervix and this is the vagina, and it's kind of contiguous. So another reason to do it is if you want a more precise removal of the abnormal area. Like sometimes the abnormal area, the dysplasia always starts here, but sometimes it can kind of extend and be close to the vagina. And you don't want to put that wire loop on the vagina in the office. It's very uncomfortable, and so sometimes it's necessary to go to the operating room, and the patient's under anesthesia, and you can be a little bit more precise as to the tissue that you get. Talk a little bit about actual cervical cancer. So these are, again, cervical cancer is when it's actually broken through this last barrier of the cells called the basement membrane. So now we're talking about stages. So again, this is the uterus, and this is the cervix, and this is the vagina. The vagina is contiguous with the cervix, and the cervix is basically just the lower part of the uterus. This is where the babies grow, and your ovaries are out here. So for stage 1A and 1-2, it's cancers that are localized to the cervix, and we call these microscopic, meaning they're literally millimeters big, and usually we can't see them with our naked eye. So these we would tell by first a biopsy, which we would just take. Remember that abnormal picture? We just take a little biopsy of it, and then if it came back with actual invasive cancer, or if it came back concerning for cancer, then we would either do a LEEP or a cone, and then so that would allow us to really see how deeply the cancer is invading, and as long as it's less than 7 millimeters in horizontal spread, and if it's only 3 millimeters deep, then it's a stage 1A. If it's between 3 and 5, it's a 1A2. So 1B1, it's a little bit bigger now. It's either greater than 7 millimeters or more than 5 millimeters. And these we can actually start to see now. Stage 1B2 is a clinically visible lesion, so like an actual cancer that we can see with our naked eye. And it's less than 4 millimeters, or 4 centimeters. So we say that cancer can spread either down or out. So stage 2A is that it's spread down into the vagina. And again, this we can see on speculum exam. We'll open up the speculum and we'll see a lesion, and we'll see it extending out into the vagina, or it's spread out, and that we can tell by doing an internal pelvic exam with our hands. So stage 3 is if it's grown all the way down to the lower 1/3 of the vagina. Stage 3B is if it's grown all the way out to what we call the pelvic sidewall. Because again, remember, the uterus is sitting in the woman's pelvis, and so it's now growing out internally into the pelvic sidewall, or this is the pelvic sidewall. And what can happen is that there's these tubes called the ureters that drain your kidneys down to your bladder, and they run right next to the cervix and the uterus, and that can actually block these tubes and cause problems for your kidneys. So stage 4 is metastatic at this point. So it's either involving the bladder or the rectum. This is a sideways view of the woman cut through. So in the front we have the bladder, which is why pregnant women always have to pee, because the uterus is right behind the bladder, and so the cervical cancer is growing. It's involving either the bladder or the rectum. The stage 4A. The most commonly, the patients we see have cervical cancer that are localized to the cervix, but a fair, greater than 50% will have what we call regional spread. Let's see. I would just say 50% have very early stage cancers where it's just in the cervix, and 50% either have it down into the vagina or out, or distant metastases. So the two main types of treatment are either surgery or chemotherapy and radiation, and it depends on what stage you have. So we only do surgery if we're able to remove the entire abnormal area. So this we definitely can do surgery on. This we can do surgery on. This starts to get a little bit tough because it's down into the vagina, which is why there's that overlap between surgery and chemoradiation at stage 2, A1 and A2, because depending on what the actual lesion is, we may be able to remove all of it with surgery or not. But once we get into stage 2B and higher, then we're not really able to do, we can't remove the entire vagina. We can't remove this entire area because it's going all the way out to the pelvic sidewall. So that's basically what drives how we treat cervical cancer. It's called a hysterectomy. We recommend, usually we recommend what's called a radical hysterectomy. And the difference between just a regular hysterectomy and a radical hysterectomy is that with a hysterectomy and again this is important because women get confused about what we're actually taking out. So a total hysterectomy means we're taking out the entire uterus and the entire cervix. It does not necessarily mean that we're taking the ovaries. Because cervical cancer actually doesn't spread to the ovaries very often, and because cervical cancer happens in young women, we want to leave the ovaries in because the ovaries are making estrogen. We don't want to put them into menopause at age 30, 35. But if for other reasons, we might do what's called a total hysterectomy with salpingo-oophorectomy. Salpingo-oophorectomy means we're taking the fallopian tubes and the ovaries. But for cervical cancer, what we do is what's called a radical hysterectomy. It's called radical because not only are we removing the uterus, sometimes depending on the woman's age, we're also taking the fallopian tubes and ovaries. We're also taking this tissue surrounding the uterus. So for more advanced stages, you have to use what's both chemotherapy and radiation. So radiation just uses strong beams of energy to kill cancer cells. We sometimes use it alone, sometimes we use it in chemotherapy. It's usually, you give it externally. It's like It's like when you go get an x-ray and you stand in front of this machine, you're basically doing the same thing, and they're delivering radiation to that entire area. Sometimes, in many cases, we deliver it to the pelvis externally, but we also want to deliver it locally, internally, so we sometimes deliver it through the vagina as well. Chemotherapy, it's a medication that we give through the bloodstream that is used to kill cancer cells. And again, depending on the stage, we use it either with the radiation or not, or sometimes we use it alone. Rates. This is what we use to say to a patient if they've basically like how long they have left to live. And the sort of the standard that we use is a 5-year survival rate. So it's basically like what percentage of patients are still alive after five years after diagnosis. The different 5-year survival rates. So you can see about 93% are, of women with stage 1A are still alive after 5 years. And that's basically, which means the vast majority of people will be cured for stage 1. But you can see it really starts to drop off even at 1B when we're starting to see those clinically visible lesions. And that's because once we get here, there's a chance of the cancer coming back. So I won't get into any cervical new stuff, except to say, we're definitely trying to do better, and we're trying to see if since the immune system plays such an important part in HPV infection and cancer development in general, we're starting to try to leverage that for new cancer treatments. So vaccines, so right now we have HPV vaccines that are available for prevention, but we're also working on what we call therapeutic vaccines. So vaccines actually produce an immune reaction against either areas of dysplasia or areas of invasive cervical cancer.